Hello and welcome to the Auditing Antics Podcast. So we're back after a little bit of a break. I had some fun health issues that kept me out of the office. Um, and then today, right before this episode, I broke my headset. So good thing I had some earbuds laying around.
Yeah, and I have a
So
cold currently, so we're doing fantastic.
yeah, we're a little bit of a hot mess lately, but we're back. So today we're going to talk about the pitfalls and what can happen when coders inside of their practices are making assumptions. And really, Michelle, I think this pertains to any auditors that work internally for their organization.
Yeah.
When people are choosing to make assumptions just because they're comfortable with their provider, maybe they're comfortable with the specialty, things like that, it really can result in a lot of issues for you on the back end if an external audit comes up.
Yeah. Yeah, I agree. It's something that I've actually been running into quite a bit recently with this whole
Well,
I don't know,
let's explain really quick. You're the external
I
auditor.
am the
So you're
external
coming in.
auditor. So I am
Yep.
coming in, reviewing the documentation, and I'm just not seeing the level of service there, the providers being a little wishy-washy. And while, yes, I don't disagree that some of these scenarios could present as high complexity, when you look at the overall picture of the encounter, it's just not there. Um, and the response you get from the client is, well, this is such and such a specialty that could be very serious, or and it's led to a couple of conversations with some of my coworkers where I think sometimes we there has to be that line. I don't
Mhm.
know,
The
there
best,
can't
well,
be.
best practices versus creating a situation that needs to be defended. And that's
Yes,
something that I
and
look at a lot.
I don't disagree that to a certain extent, you brought up something really good. You get comfortable with the specialty. And this was a discussion that, me and my coworker had, that would it have been, not so gray if it were a specialty that we were more familiar with, that it was
Mhm.
something that we knew a little more. And to me, no. I feel like I try really hard to not read between the lines, even when there are certain conditions that I know a lot about just from personal experience, like complications of diabetes, kidney disease, hypertension. I really try to put that hard line in the sand and say, you
Mhm.
have to show me how these things are complicating the care on the state. You can't just say it's there and then not associate anything and then make the assumption that this is higher complexity just because you've said this is present. So I think that there's a line that has to be present, and as an organization you really have to be able to put that line in place and determine what level of risk is acceptable for yourself, but also
Well, and
understand that you may have to defend it, that
mhm.
if you want to consider these certain things just because of the specialty that's being coded for, then you may find yourself in a defense situation.
Mhm. And one of the things that I've been thinking about a lot lately, even in my own audit reviews, is the fact that we now have auto downcoding happening already. We have Cigna announcing that they're going to start doing
Yep.
that as well. And for me, and I've said this before, I think it was on Sean's podcast, but for me, yes, I'm extremely frustrated by that because how could you tell from data alone if those
Hmm.
different things are supported in documentation? So I'm heavier on that side of things. But when we break it down and look at a lot of the organizations that we work with, a lot of times there is education and feedback needed. And that's
Yes.
also playing into this entire issue. So, as an organization, when you have somebody coming in who has experience like we do, what are you doing to help yourself if you're pushing away the feedback that you're receiving or wanting to argue a point on it when we're looking at things from a preventative perspective, we're doing
Yes.
that for education, for best practices. As external consultants and auditors, our goal is not to create a situation that has to be defended, but there's definitely times where the clients that we work with will push back and want us to, go to their side and assume things. And then
Yeah.
also, Michelle, I've been in the situation too, working internally for organizations, and they sometimes don't want the feathers ruffled, right?
No.
They want the claims to just go out. They don't want us to point out issues we're seeing. They just want it submitted.
And I think that sometimes that's a really good point. Sometimes we sit and we have these feedback sessions with providers. Um, you know, I that's not something that I've really been interested in doing here as of late. Um, so it's been a while since I've been doing those feedback sessions with providers, but I have sat in those where I have had to explain to a provider and they didn't like that I was telling them that their note was not clear, that they needed to do a better job of conveying the severity as well as their thought process behind why they were choosing a certain treatment plan for this patient. And just because they may not like to hear that, just because you get yelled at by a provider for bringing this feedback to them doesn't necessarily mean that it's okay to say, well, this is the specialty and these things can be really bad. Think about it. That's really bad. When the provider has not clearly given the severity of the problem in their documentation. And there's a few ways that you can do that. I'm not saying that providers have to go out there and say this is a severe exacerbation for something to be considered high complexity. I know that that's a common misconception. And sometimes when you start seeing that templated language in relation to severity, it can really take away from the impact of that statement. So I'm not saying that I expect to see those particular words in the note, but you have to have some way of showing the complexity and severity of a patient. You can't just make the assumption that because they presented with this and this could be a really bad complication of this, but you end up doing nothing about it. How do you support that as high complexity is my question.
Well, and on the provider side, we get asked sometimes, for example, I was asked recently about pediatrics, and the practitioners who were asking were telling their compliance department that they didn't feel that the audits could be conducted unless people understood pediatrics clinically. And, that to me, just said, okay, well, there's very common things with presenting problems in pediatrics that are not automatically going to be moderate, but our clinicians think they will be. So it led
Yes.
to a lot of conversation around what the guidelines are. And, for example, a big one, they were stating a fever in an infant, a child under 1. Okay, well, I do know clinically from my work and meeting with pediatricians that that is higher risk. But if all you do is leave up to assumption because of the age of the patient in the chart, that's not going to show that that's a complicated case compared to
No.
another patient.
And we have to remember that from a the response to that provider right away should have been, um, well, there's a difference between documentation for billing and documentation for continuity of care and clinical use. As a coder
Mhm.
and an auditor, we are not allowed to clinically interpret anything from that note. We are not clinicians. We are not clinically trained. And I think that is where I know that's something in my mind that I really try to hold true and fast to as I'm auditing. And I think as a result, it does make me a little bit more of a conservative auditor. I
Mhm.
do try to, I'm not going to say read between the lines because I don't. If it's just not there, it's not there. And we can't make an assumption based on age, like you were saying. So I think it's really important that when I used to do education sessions with providers, I would start the very first things out of my mouth were, we're here today to look at your documentation from a billing perspective. And
Mhm.
as a coder or auditor, I am not allowed to clinically interpret your documentation because that is not my role as the coder or the auditor. So when we speak today, I'm not looking at this from a clinical lens. I'm not qualified to do that. So we may have to work together to understand what happened here today, and then we can come together and figure out how we can better convey that in your documentation for non-clinical review.
Mhm.
And
Yeah.
when I would start with that, I think it would kind of help them see, like, we're not just stupid. Sometimes,
Yeah.
we all make mistakes and we're like, oh, when we're sitting there, we're like,
Oh, crap.
oh, this is not good. I feel stupid. You know what I mean? And it's okay. But though that is how I would lead those
Mhm.
those types of encounters that I was having. And I found a lot of success in that because it helped them, it kind of set that precedent from the get go that we're not, when it comes to billing, we're not looking through a clinical lens because we're not
Mhm.
qualified. I'm not the doctor. Um,
Well, and along with that, that really leads into the types of conversations that you also want to open up to the provider that you're meeting with. Because a lot of times I find, in their mind, they know the patient, they know what happened. And, yes, we do get less detail for sure in documentation than what's actually occurring. So, in that situation as well, I always like to get their thought process on the individual patients because that'll help bridge that gap that you're talking about as well,
yes,
Michelle, where we
yes,
can see, okay, is this a misunderstanding of the guidelines where we need to help clarify that for them? Or
yes,
is it a situation where the scenario absolutely supported it, but the documentation was deficient?
yes.
So those types of open conversations and making sure that you're not coming into that ready for confrontation and things like
No,
that.
no, you
That's
want
only
to
going to start an
present
issue.
it like you're there to work together. You
Mhm.
have,
And
I'm
hopefully
going to
you
say a
are.
mystery because I'm really into Murder, She Wrote.
Oh,
You
yes.
have a mystery in front of you to solve, and you need both perspectives to come together and solve that mystery. And even though it would be ideal for no note to be a mystery, um,
Yeah.
we have seen our fair share of mysteries in documentation. But it's really about working together as a team. And I think as I have encountered providers that view documentation, one is like, oh, this is just for billing. I'm going to check these boxes. And then others are like, this is for clinical use only, and it's like, well, you do have to understand that this is a legal document used for billing as well. So
Mm-hmm.
while clinical continuity of care is extremely important, you also have to remember that it's a dual purpose document and
Hmm.
serves a couple of different purposes.
Yeah, definitely. Well, and one thing that I want to touch on before we end today is related to what these assumptions can do in the event that those external audits occur. So, we can say all the time it's creating a compliance risk, for example, but, think about the scenarios where we have, for example, a physician in a hospital and they see maybe they're an intensivist, so they think everything's critical care or everything is high risk and
Yes.
nothing would be below. When you get into the scenario of external auditing, you're going to be in a situation where that person does not know that provider personally. They do not know we'll hear from a lot of people, well, our hospital has more complex patients or in our region, or
Yeah.
I've even worked with pediatric specialists that are the only in their state. So yes, that type of thing can happen, but those things alone do not drive. And
No. No.
we have to think about how to push back if we're feeling that pressure internally, because it's
Yes.
easy for me to say, and now Michelle with you external as well, we can sit here and say, well, don't make the assumptions, but what do you do when you have a physician who is constantly mad that his stuff is being downcoded, or wants to look at every little thing and
And
every encounter's an argument.
and one thing that I can say is if somebody has gotten to the point where they are an external auditor, I do believe they started out in a position where they were dealing with those types of things. I know I did. I
Mhm.
I had those situations where things were being downcoded and the providers were upset. And we had to have, you know, in some of the instances there was training needed on both sides. But at a certain point, you have to take a look at where is that anger coming from. And um, once again, no matter what position you have or who you are within the organization, you do not have the right to treat anybody in that manner. I
Mhm.
have had situations when I was coding where providers called up yelling, and that's not okay. That is
Mhm.
not a precedent that should be set within your organization. And so just remember, let me get back to my original point, but when an outside auditor is looking at this, they likely have been in that position as well before, where they have had those providers mad and saying, well, it's my judgment, I'm saying this is high complexity, so that's how you're going to bill it. um, those are issues I think that go a lot further than just
Mhm.
compliance. I think there's other issues at hand there that need to be dealt with. And if you find yourself in those scenarios, you need to go to your leadership and you need to say, this is not okay. Like, I can
Mhm.
understand frustrations and not liking that something has been changed, or we are saying something is not supported, that their documentation didn't support what they're wanting to bill, but you still have to have respectful interactions because we are all professionals. And I think that's something you need to be able to bring to your leadership. And there may be bigger systemic issues involved. I think we both have worked in hospital systems, Stephanie, where we have seen those issues where bad behaviors have been allowed. And it's something that has to be dealt with separately than the compliance concern. But not wanting to ruffle feathers is not a reason to allow poor documentation, in my opinion. That's not, you're not going to be able to sit in a court of law and say, well, I was going to get yelled at if I said that to them. That nobody's
Mhm.
going to accept that as a valid reason. So
Right. Well, and I think the key is making sure, like you said, going to leadership, because
yeah.
it's something where you need to have that documented. You can even keep a log and, show, okay, this encounter is supported at this level. I don't agree. Michelle, I know you and I over the years have talked about situations where you've had to go back to your employer and say, look, I'm not comfortable with this. It's not
Yep.
supported. If somebody wants this submitted, you're going to have to do it. My name's not going on it.
Yep.
Um, and you were a little external, so it wasn't like you were inside that practice, but if you're inside a practice, you need to be careful. You need to be watching what's being done. You
Yes.
know, a lot of times when I work on cases from a defense standpoint, you know, a practitioner will try to throw their billing staff or their coding staff under the bus.
Absolutely.
It doesn't necessarily always work, but if you are wrapped up in a part of these issues and the fraudulent claims that are going out and things like that, that can be problematic for you. And, you know, you have to think about that. And,
Yeah.
you know, unfortunately, I think a lot of people stay in bad situations and bad positions because they're so desperate for the experience,
Yeah.
but
And
it's a big deal.
it is. And I did ultimately have to make the decision to leave. Um, one of the places I worked prior just because of how I was being treated and how they were allowing us to be
Hmm.
treated, and it's not okay. But then I worked in another environment where I said, you know, we had a discussion. I wanted to hear from them why they say it's supported. Give me your rationale for why it's supported. I will give you my rationale for why it's not supported. And after we had that discussion, they didn't have a rationale. They were basically
Hmm.
wanting to do it because the provider said to do it. And that's when I said, you know, I'm not really comfortable submitting this batch on my own. And thankfully, I had some great leadership in that company, and they said, okay, we 100% understand, and we will take that off your lap and we will do what needs to be done with it. And I was really fortunate in that instance to
Hmm.
have that kind of leadership that listened to me. And when I said, no, I'm still uncomfortable, this is the reasons I'm still uncomfortable and why I don't think this is compliant. Um, they listened and they said, okay, no problem.
Hmm.
And there was no type of retaliation, backlash. So I had a lot of respect for those individuals and how they how they chose to handle those types of situations. And it really was
Hmm.
not lost on me how fortunate I was to be a part of that team.
Yeah. Well, and for sure. So that, you know, that's going back to the whole point of needing to gauge that for yourself and look at the environment you're in, all of those things. You know, other opportunities can come along, and you've got to make sure that you're remaining compliant and also helping your organization remain compliant. All right, now we're going to go ahead and end here for today. We will definitely be back next week. And just a quick update to everybody, I've been sharing out on social media lately. Terry Fletcher and I from Terry Fletcher Consulting are going to be presenting and hosting a webinar event for telehealth services. So if you go to the homepage of stephanieallardconsulting.com, you can get some more information on that. We're going to spend an hour and a half together digging through where everything's at, what potentially is going to be expiring, and where that's going to be in the future. And you know, it'll be fun to get together as a group and talk through where everyone's at. I feel like we need a hard reset right now in telehealth, and we're trying to just come together and provide that for everybody. So check that out on my website, stephanieallardconsulting.com. There is approval for 1.5 CEUs. So if you have any of your credentials through the major organizations, we have that listed there as well. But um, that will be approved for that CEU. All
Awesome.
right. Well, we will see you all back next week.